Hello. Welcome to the November edition of Thomson Reuters AI at TR Invited Speaker Series. I'm Jack Conrad, a director with Thomson Reuters Center for AI and Cognitive Computing and the organizer of this series. My role today is to provide you with the background of one of our colleagues who will be introducing today's guest speaker. Sharon Sales-Belton is the Vice President of Strategic Partnerships and Alliances for Thomson Reuters Government Division. Her responsibilities include the development and management of private sector partnerships that serve our government customers. She also provides oversight and management of the community engagement and employee volunteering in key locations. Sales-Belton served as the mayor of Minneapolis from 1994 to 2001. She was the first woman and the first African-American to be elected mayor of the city. She achieved national recognition as an expert on public-private partnerships in public safety, neighborhood revitalization, and economic development. Sales-Belton began her career with the Minneapolis Department of Corrections as a probation and parole agent, and later served as the assistant director of the Minnesota Program for Victims of Sexual Assault. Sharon Sales-Belton, thank you for your role here today. Please get us started.
Well, thank you so much, Jack, and good morning to you and all of our guests today. I would like to join you, Jack, in welcoming everyone to this edition of AI at TR Speaker Series. Today's talk is presented to all of you by the Legal Executive Institute and sponsored by TR Labs and our Center for AI and Cognitive Computing. I'm delighted to be able to say a few words about today's invited speaker, Dr. Michael Osterholm. Now, I've known Dr. Michael Osterholm for a number of years, and I think most of you on the call will know that he is a renowned public health expert. He is a Regents Professor and the McKnight Presidential Endowed Chair in Public Health. As well, Dr. Osterholm is the director for the Center for Infectious Disease Research and Policy at the University of Minnesota. He is the distinguished teaching professor in the Division of Environmental Health Sciences at the School of Public Health. To add to that list, he's also a professor in Technological Leadership Institute in the College of Science and Engineering and an adjunct professor at the medical school, all at our University of Minnesota. From June 2018 through May of 2019, he served as the science envoy for health security on behalf of the United States Department of State. One of the things Dr. Osterholm is perhaps best known for today is the book that he authored in 2017 entitled Deadliest Enemy, Our War Against Killer Germs. In this particular book, he details the most pressing infectious disease threats of our day, but lays out a 9-point strategy on how to address them, with preventing a global flu pandemic at the top of the list. Certainly a timely topic for us today. As if that were not enough, Dr. Osterholm is also a member of the National Academy of Medicine and the Council of Foreign Relations. Dr. Osterholm was previously appointed to the newly established National Science Advisory Board on Biosecurity. He has also been named to the University of Minnesota's Academic Health Center's Academy of Excellence in Health Research. In October of 2008, he was appointed to the World Economic Forum's Working Group on Pandemics. Suffice it to say that today's invited speaker is one of the world's top authorities on the kind of pandemic that we are currently confronting. He has been a guest, on a number of news programs over these past several months. On a personal note, I'd like to say that when I was serving as the mayor of Minneapolis from 1994 to 2001, our city's health department collaborated with Dr. Osterholm's group at the University of Minnesota on a number of occasions. What I remember most is that his department supported and helped develop the 1995 homicide study that really led to the development of a comprehensive crime prevention strategy for the city of Minneapolis, which, was very successful. In fact, within a year and a half after adopting many of the strategies that were informed by his research, we were able to significantly drop the crime rate down in the city of Minneapolis. I was then, and I continue to be, in Dr. Osterholm and his team's debt. That said, without further introduction, I'd like to welcome Dr. Osterholm today for his talk on the COVID-19 pandemic, the evolving reality. Thank you so much, Michael, if you don't mind me calling you that, for joining us today. Before Dr. Osterholm presents his talk, I'm going to turn things over to Axel Threfall. Axel is Thomson Reuters, is Reuters editor at large, and Axel is really going to be moderating the question and answer session that will follow the talk, which I know we will all enjoy, from Dr. Osterholm. So, Axel, let me first throw it over to you.
All right. Sharon, thank you very much indeed. And actually, I think the way this is going to work, and if it's okay with Michael, is we're going to do a conversation right from the get-go. And then we're going to open this up. To the audience. So thank you, Sharon. Apologies, by the way, to listeners if they're getting a little bit of an echo. We're trying to sort that out. I've also got a bit of an issue with Michael's camera, which we will also endeavor to sort out as well. I've spent a lot of time, probably too much time over the past 6 months, speaking predominantly with policy and business leaders about this virus. A lot of time trying to interpret often confused and mixed messages about the direction of travel. Not enough time speaking, I think, with the scientists, the doctors, the researchers, the academics, whose job it is to look at the numbers and tell us in a calm fashion what's really going on and what might happen. And Michael Osterholm sits firmly in that category. Michael, a very warm welcome. I hope you can hear me okay.
I can. Thank you very much, Axel. It's good to be with you.
Good to have you with us. Look, I want to start with something you said last week. I heard you say we're entering into the darkest days of this pandemic. Now, without wanting to encourage scaremongering, although some might argue that's exactly what we need more of, what will the next weeks and months look like, Michael?
Well, my job is just to call balls and strikes, to tell it as it is, so that we can, in fact, anticipate what the issues are, what we need to do about it, and, not sugarcoat it, nor at the same time, as you said, scaremonger. It's just, what are the facts? The facts are that we are seeing a very marked increase in transmission of this virus, not just in North America, but also in Europe. And let me just concentrate on North America. In the emerging pandemic in April, we saw when we had, in a sense, a house on fire in New York City and some of the other selected cities, Detroit, Chicago, and so forth. We were, at that time, reporting about 32,000 cases of COVID-19 a day. And clearly we had a very substantial increase in deaths. For about 3 weeks, this became the #1 cause of death daily in our country, COVID-19. Well, at that point, then we talked about flattening the curve, and we asked people to, distance themselves, not be in public spaces and crowds. And with that, we actually were able to see the cases come down to about 22,000 cases a day in this country by Memorial Day. However, at that point, people began to become increasingly tired of this quote-unquote lockdown or distancing. We saw the protests, which brought out a lot of people into public places. That then made it seem as if public places were just fine to be in. And then you know what happened. We saw the increase over the month of June, July. By mid-July, we were reporting out 67,000 to 70,000 cases a day. And the same thing happened again, particularly in the states of Georgia, Florida, Texas, Arizona, California, where we had distancing come into place. We had intensive care units overrun that were on the news every night, and people then basically took steps to limit transmission by not sharing air with someone else who might be infected. Well, that brought the cases down to about 32,000 by Labor Day, the same number, by the way, which was at the height of the peak in April, but we thought we had done a great job in that. And at that point, we really had the confluence of pandemic fatigue, this concept of people who believe that the pandemic is real, but at this point are just basically wanting to move on with life, that this has been a very difficult period. And so we saw people going into bars and restaurants, going back to churches. We saw major events around weddings, funerals, family reunions, gymnasium participation, et cetera, and including the opening of colleges and universities. Well, at that point, that then overlaid with what I called the emerging world of pandemic anger, where we had up to a third of our population that actually believes this pandemic is a hoax, that it will go away this Wednesday, and that it was politically motivated the entire time, a group which is not at all willing to consider public health measures for reducing transmission since they don't believe the pandemic is real. Then you add in the final mix of that, which is the issue of indoor air. We know that most all the transmission occurs as a result of breathing in someone else's air that they exhaled out that had the virus. And indoor environments are much, much more conducive to that transmission. So if you put that all together, pandemic fatigue, pandemic anger, indoor air, and then you can see what's happened, where this past week we hit almost 100,000 cases per day. We're seeing major challenges in the upper Midwest. At the same time, we have 41 states right now with major increases in transmission, which are just not far behind the upper Midwest. And then now you add in the holiday season coming together, where people still want to get together with family, traveling distances, taking the virus with them, even though they may not know they're infected at the time. And I just see that this pandemic is really going to hit its very, very worst between now and the first of next year. Don't be surprised when we blow way past 100,000 cases a day. Finally, I'd say, why do I say now is the darkest time? Because I hope, and realizing hope is not a strategy, but we will be able to roll out vaccines by the end of first quarter next year in some meaningful way, second and third quarters, clearly, where we'll have more vaccine available, which could really blunt the pandemic to some degree. But so between now and then, nothing is good about this pandemic, just nothing.
Michael, thanks for laying that out. You talk about blunting the pandemic with a vaccine. You've in the past cautioned against relying on a vaccine to end this. You've said it's going to bring real improvement. I mean, just how much of a panacea is a vaccine going to be, and how deluded are we to think that this is going to be the be-all and end-all solution?
Well, first of all, you have to break down how a vaccine works in two ways. One is, what does the actual vaccine itself do to protect you? And number two, who uses it? In terms of the actual protection, right now we're hopeful we can get 50 to 70% protection out of these vaccines. And in terms of what kind of protection, we don't know. Meaning, is it going to protect the milder illness cases? We know, for example, with influenza virus and vaccine, the same people who are at high risk for having bad outcomes, i.e. those who are older, those with underlying health conditions, those who have high body mass indexes, are also the same people that don't respond that well to the vaccine. So we have a challenge there with trying to protect the severest of those cases, not just cases in general. And we don't yet know that about this vaccine. But also survey data that we have from the community, and particularly overlaid on this era of political unrest, you might say, we have over 50% of the U.S. population right now is skeptical of even taking the vaccine for safety reasons. Well, if only 50% of the people take it, and the vaccine is only 50% effective, that's only 25% of the population will be protected. Add that on top of the 10 to 12% of the population that's had the virus infection to date, and develop some immunity, that's only 35, at best 40%, far short of the 50 to 70% we would need to actually slow down transmission. So, at this point, we still have to realize that we may have substantial transmission going well into through next year. One of the last challenges we have is a concept called durable immunity. Durable immunity is protection that lasts over a period of time and is effective against all aspects of the disease, moderate, severe cases. And we know with coronaviruses, they've historically been a real challenge that way, that achieving durable immunity is a real problem. It may, for most people, it may last a year or two in terms of protection, but not much longer. And so we have a lot of work yet to do to understand, are we going to be talking about vaccine programs that will have annual boosters, much like we think of with influenza? This is still a lot of information that we have to better understand before we can say exactly what the impact of the vaccines will be.
I've heard you say before, I'm pretty sure as you, Michael, that the storytelling is every bit as important as the science itself. And I wonder who you think has the storytelling right. Based on what you've just said, do we need to be getting the message from our governments, from our leadership, that COVID-19 is always going to be with us, just like a seasonal flu? Does that need to be the storytelling?
Well, yeah, I think a really important aspect of this, and when you're asked about storytelling, I described that in some length on Meet the Press 2 weeks ago when I was on. What we need right now is an FDR. We need someone to provide us with a vision of what is coming, not sugarcoated, but at the same time give hope and say, so what can we do about it? What is it that we can actually do? And right now, we don't have that. We are an echo chamber of he did really well or he screwed up. And we're not really understanding what the challenges are. I go back to January 20th when I wrote a piece that said at that time, this is going to be a pandemic. Get ready, everyone. And yet it took the world 2 months after that before they finally declared a pandemic. At the time, people said, oh, my, you are just scaring the hell out of us. Don't do that. And yet we needed to be front and center telling the people just what we know and don't know. And so I think the storytelling is what is really critical right now, because when we ask people to basically distance themselves now, that's what they've heard since last spring. And they're saying, why? What's the end game here? And we need to tell them what we're trying to do is get as many people as possible through to next spring to get the vaccine, as opposed to actually having to get clinically ill with this virus. Some will say, well, it's not a big problem. It is. And number one, the deaths are going to start going up precipitously as they're a lagging indicator, at least 2 to 4 weeks behind the new case numbers. And we're seeing that. We're seeing intensive care units in a number of places in the United States as well in Europe that are overrun. And the quality of care is going to drop precipitously over the days ahead as they're overrun. And mind you, if you have your heart attack or your stroke or other conditions during that same time, you're going to be challenged to get quality care because it's so overrun by COVID-19. Well, then on top of it, what we're seeing right now is, particularly in young adults, 20 to 40 years of age, this ever-increasing occurrence we call long hauler's disease, up to 20 to 25% right now of individuals who have very mild COVID infections and kind of like, oh, this is no big deal, who at 5 or 6 weeks after that are now in finding themselves with severe fatigue, what they call brain fog, with damage to their lungs and their hearts, in such that, I know of people who are right now on 100% disability, on 100% oxygen at home, otherwise previously healthy 35-year-old marathoners. And so we want to tell people, you don't want to get this virus. That's the story we have to tell. We have to start telling stories and helping them understand that this is not about government's long, hairy arm trying to restrict you and what you do, understanding the economic issues. And I just close this by saying, last August, Neil Kashkari, the president of the Minneapolis Federal Reserve Bank, and I actually wrote a piece in the New York Times, an op-ed, saying now is the time to basically limit contact. In the sense, I hate the term lockdown because it means so many different things to different people. He said, if we did this for 3 to 4 weeks right now, we could get the case numbers way down. And we could then keep through contact tracing, testing, quarantine and isolation, keep them at a very low level, just like the Asian countries are doing right now. Go look what's happening in Asia. They're handling this thing quite well. And so we could do that. And on top of it, because the savings rate had gone from 8% of income to 22% at such low interest rates, we could borrow the money from ourselves, pay ourselves back to make sure everyone is held whole. So if you lost your job, if your business suffered, if you're a city, county, or state government, we could help cover that with that money, and that we would actually be where the Asian countries are, not where we are today. And that's the challenge. We have to tell that story.
Yeah, I'm going to come to Asia in just a second, in particular China. But just based on what you've just said, and based on what you've heard, Michael, and look, I know you've got a big day coming up tomorrow on the political front, but does a Biden presidency get the storytelling right?
Again, I've served roles in the last 5 presidential administrations. I've served 2 Republican governors, 2 Democratic governors, 1 independent governor, a state epidemiologist here in Minnesota. And, no one would know my political partisan leanings. I'm in here to call balls and strikes. That's why people get upset with me sometimes when I say we're only in the 3rd inning of this game. We're not there yet because we have so much more to go. I will tell you right now that if Dr. Scott Atlas in this administration is ultimately put in charge of the coronavirus task force on Wednesday, it will lead to further public health disaster. Not a partisan comment, just fact. It will. He has no understanding really of the epidemiology of this disease, what needs to be done. And I can tell you, if you're looking at 230,000 deaths to date, if we let this just go willy-nilly, even to the point of getting the vaccine, we're going to be looking at anywhere from 500 to 800,000 deaths between now, as a total, between now and the spring. And we will bring this economy down. Look what it's doing to the economy now. And I can tell you that it's only going to get much, much worse. So, the narrative that I see on that side of the aisle is not one that will be in any way, shape, or form helpful or successful. I think Vice President Biden's administration likely will have a very different approach. They will utilize a lot of the public health expertise that's available to help really reduce this, to try to look at it. How does Asia do what they've been doing? And so, again, I'm not here to, just call balls and strikes, but my belief is that what will come from that administration will do much more to save lives and actually to stabilize our economy.
Okay. And I'm just going to follow up with one brief question on that, and then we'll move away from the politics. But the storytelling for the health piece is very different from the storytelling for the economy piece, right? And often they're at odds. And I just wonder if a Biden presidency gets the health storytelling right, it doesn't necessarily mean he gets the economy storytelling right.
Right, it is. You're absolutely correct. You have to get both. But the bottom line is you can do both. This is not, magic. It's not pixie dust. But in fact, if you bring the virus under control, you actually also have major implications for your economy. Look at Europe. Europe was doing a great job after the initial house on fire in April. And they knocked down the infections and held them down, and they were coming back quite well through the summer. Then because they felt like, well, we're 6 months out now, things are getting much better, they basically let up very quickly off the brake, and look what happened. You can see. On the other hand, you have Asia, where basically, just take Australia. I think this is a good example. In July, Melbourne was a house on fire. And they put together some very strict requirements in terms of distancing and so forth, not well liked, but at the same time, basically very effective. Today, Melbourne's just gotten the last 3 days without a single case. They're opening back up again very carefully. They're watching it in a way that they should be able to stay on top of it and control it. So I think that's what we've been talking about is, you can't fight a major forest fire with one county's fire trucks. You need a super team of firefighters to come in and do that. And until we can actually get that down, then we really, we're going to have a problem until we get those numbers down. Then we can control it. And right now, we are in no way controlling it here.
Michael, you talk a lot about Asia, and the times I've personally felt most optimistic about the future have been when I've spoken to some of our correspondents in Greater China. I spoke to our Greater China bureau chief a couple of weeks ago, and he said, things are pretty much back to normal here. And that, of course, gave me great hope. My question is this. Do you believe things are pretty much back to normal in China? And how did they get that so right, do you think?
Well, first of all, I think it's a mistake to focus on China. I'd focus on all of Asia, because one can conclude from China that it took the communist country authoritarian overview to do that, okay? And that in fact, that was what was the requirement. But if you add in New Zealand, Australia, Singapore, Taiwan, Korea, Japan, and probably Vietnam, which has been one of the greatest successes, they all use various aspects of government oversight intervention. But what happened was the populations were compliant. They were willing to be tested. They were willing to provide contacts. They were willing to isolate themselves if, in fact, they were infected so they didn't transmit to others. And they did that without, any kind of criminal persecution, that kind of thing. Surely people had to be held accountable. So I would add all those countries, because I don't think most people would think of New Zealand and Australia in the same category they think of China. Yet they all did the same thing. So it's not you have to just have an authoritarian government, but you have to have a government whose leadership is such that the population will follow that leadership, whether it's because they just are, that's what they know to do, or that's because they believe in their government to do it. And so I think that things are much more back to normal in these countries, not at all perfectly back to normal, but if you look at GDP of China, you look at all these countries right now, what's happening, they actually are going to be in a much better position to get vaccines in there next spring with a limited amount of both hit in terms of health and a hit in terms of the economy.
Yeah. And so in many ways, it does come back to politics, doesn't it? You respect for leadership, effective messaging, effective communication from those leading the country. It does come back to politics in many ways.
It does. And it comes back to leadership. I mean, I think that's where, if you have someone like an FDR, and I know that, that may seem romantic in the sense of, oh, it can't ever be like that again. But in fact, I think that the idea of telling stories and being able to help people understand where we're at is not going to be a perfect solution. There'll still be those who believe the earth is flat, who believe any vaccine is a poison or a toxin, and that this virus doesn't exist. It's just a function of a political statement. There'll be those. You can't change that. But there are many, many more who are looking for the hope. They're looking for just somebody they can believe will tell them what's really happening. And the thing I fear most is the conversion of people from the doubting, not willing to comply with trying to limit their contact with others, will eventually do that. But they're going to do it in a very, very painful way. And what I mean by that is that if I'm sure there's many people on this call who can identify with the fact that, I'm late for a meeting, I'm driving down the interstate 10 miles an hour too fast, I shouldn't be doing it, and I come upon the scene of an accident, and my heart goes pitter-patter, I slow down, thinking this is crazy, and I do that for a couple of days, then I'm back at it again. On the other hand, if I get a 2 a.m. call in the morning, and I just had a loved one killed by a drunk driver, you know what? I never forget that. I make it a cause in my life. I think you're going to see more and more of that happen with COVID. You're going to see people who don't believe this is real, only to have transmission occur and their households or wherever have mom and dad or grandpa and grandma die from it, and they change their tune. Last week, I had one of the most painful conversations with a young woman who came home from travel, brought the virus with her back to her home. Unbeknownst to her, she was infected. And 3 weeks later, her grandmother died as a result of exposure to her. She's living with that the rest of her life, almost like the drunk driver has to. That's what we're trying to tell people. You don't want to have that. And when you can tell the story how to avoid that, why that is important, you can visualize what it means. I don't want to infect my grandmother. Oh, my. That's the story we're not hearing right now. We're just hearing about you got to do this, or you got to do that, or you can't do this, or you can't do that.
Yeah. Okay. Look, we've got plenty of questions coming through, and quite specific, and I want to get to some of those in just a while. But a few other bits and pieces that I want to come to. You mentioned COVID fatigue, and we've got this new term, COVID anger. Now it seems to have sort of graduated, I guess. As someone who spent much of his professional life working, studying not only diseases but human responses, physically and mentally, to diseases. I wonder, how prepared are we mentally, do you think, for something like this collective trauma, if you like?
Yeah, I think this is one of the challenges. I just did a podcast last week. I do a weekly podcast. And the title of the podcast was, Finding Light in the Middle of the Tunnel. Not at the end of the tunnel. We're a long ways from that. But how do we find light in the middle of the tunnel? What do we do for our own mental and physical health? What do we do for our economic stability? How do we at this time put this all together? It's a time of the year where we already know that it's challenged with the holidays and all the mental stresses of that. We know that, with the shorter days, we have seasonal affective disorder. We already know that economically people are very stressed out right now, and reasonably so. And so, when you add this all up together, you have to also address that at the same time you address the virus. Let me tell you, probably the most painful moments in recent weeks that I've experienced with this, and actually shed a number of tears, have been listening to healthcare workers tell me how broken they are right now, spending day after day after day in these intensive care units. I had a male nurse last week describe to me what it's like on one morning to have to hold the hands of 4 different people as they died, all alone, because there was nobody else there, because family couldn't be there, and how he feels so broken about that. We are watching our healthcare system right now go through the most classic post-traumatic stress syndrome event probably of modern history. And so, we have to deal with all of these other emotional issues as part of the storytelling. How do we help people? How do we get people to get support? One of the things that was most interesting, and I'm sure people on this call will probably scoff at my saying this, but, on one of my podcasts, I explained to people, I have accessed, mental health therapy throughout my entire life. I've seen a therapist. And you know what? It's been the best thing. I'm not afraid to say that. I can't tell how many men got a hold of me afterwards saying, thank you for saying that, because I've always felt like I couldn't go do that because it's not something men do. And you know what? Right now, we need to access every bit of help we can get, whether it's physical, mental, emotional, and storytelling is part of that.
What about, just on the collective side to this, the collective trauma, whole villages, towns, populations, the fact that we're dealing collectively with something like this, to what extent does that help, you think?
Well, I think that's, again, part of helping everyone realize this is not us versus them. It's us versus a virus. And we're trying to find out, how do we do that collectively? How do we work on that together? For example, as I said earlier, Neil Kashkari and I wrote this piece in the New York Times about how to minimize economic implications of basically distancing, the idea of what people call shutdowns or stay-in-home orders, et cetera. And knowing that the first thing you think of is, I'm losing my job, I'm not going to get paid, I'm losing my business, it's going under. Governments, where am I going to get the resources? And we said, we shouldn't be out there asking people to do the impossible. This is where, from a modeling standpoint, financially, actually, countries do better by investing that kind of resources in, as I pointed out earlier, borrowing money from ourselves to pay ourselves at low interest to keep us afloat. So when you tell that story, that's the story you have to share, is that we're in this together, and this is how we're going to take care of each other. And right now we're not. We're telling the story about how we're going to be angry at each other. We're telling the story about how we don't believe each other. We're telling the story about how this is a hoax, and you're perpetrating this on me. So I think that's really a key message we have to deal with.
Yeah, yeah. Michael, I'm going to get to a few questions from listeners, and then I'll come back to our narrative. But they're quite specific, some of these. But now we're entering the winter season, is one of these questions. I'd like to know, for indoor environments, how well do air purifiers work to limit spread?
Well, that's difficult for me to answer because there's so many factors that go into indoor air ventilation, HVAC systems, heating and cooling. It's the room size, it's the number of people that are in the room, it's the actual movement of air in the room, how fast does it turn over, how is it recirculated, is it new air, is it filtered, whatever. And so there are so many different pieces. It'd be like kind of asking me right now, if I'm an architect, how should I build my home? Well, I'd want to sit down with you and go through a whole lot of things before I, even begin to answer that question. And so at this point, I think it's fair to say that it is a very important area, a very, very important area. But at the same time, it is one where I can't, give you specifics other than to say indoor air is a real challenge.
Can children under 2 transmit this virus?
I'm sorry. Could you just repeat that? You broke up.
Yeah, another question. Can children under 2 or very young infants, can they transmit this virus?
Oh, yes, they can. But it's a very, very low risk kind of setting in most situations. We have, at this point, clear evidence of transmission of kids. And one of the things that's a challenge with kids, by the way, is the fact that we're talking about kids as if somehow, newborns to high school students are kids, and they're not. They're very different with the risk of transmission in terms of this virus. With those under age 10, a much lower level transmission problem occurring there. It does happen. It's where you get into more of the social settings and you get into adolescents and young adults where you see a lot more transmission. Right now, we have many examples of transmission that are occurring in high school and junior high related sports, social events, etc. So it's a real challenge.
Yeah. You still there?
Pardon?
Are you still there, Michael? Yeah. Oh, yeah. Sorry, I thought I'd lost you for a second.
No,
look, I want to speak. Okay, great. I want to ask you about herd immunity as well. We hear a lot about herd immunity. I'm sitting in London. We heard about herd immunity back in sort of February and March. A lot of really mixed messages here. A lot of confusion. I'd like to hear from someone as level-headed as you whether you think this is worth us talking about. Do we want 70, 80, 90% of the population infected so that we can then move on?
Well, first of all, let's just back up. Herd immunity is a concept that is all about the level of transmission in a community of a virus, particularly like a respiratory virus. And it varies by the infectiousness of the virus, how long you're infected, what level of transmission occurs, what is your contact with other people, how frequently do you get together, what kind of mixing occurs in the population. So it's a dynamic concept. But in short, very highly infectious viruses like measles, you need 95% plus of the population to be immune, or else this virus will find the people in that community who are not infected and you'll see transmission. With this virus, it's a very challenging concept because what we know is that certain members in the community are likely to transmit to quite a few people. They're much more highly infectious, and we don't understand why. Others are much less infectious, still transmitting, but less infectious. And kind of the standard rule of thumb right now for this is that about 20% of the infected COVID-19 individuals transmit to probably 80% of the next generation of cases, meaning that it's more of these people, and this is where aerosol transmission becomes a really key piece of how this transmission occurs. So it's not just as simple as saying, okay, if you get this percentage of people immune, you're going to stop transmission. With herd immunity here, what we're talking about is if we have 50 to 70% of the population immune. So think of it like a big virus transmission reactor. And we're putting rods in it that are either immune from natural infection or immune from vaccine. If you get to 50 to 70% of that population, then transmission slows down, doesn't stop. It's going to keep going until it basically tries to infect everyone. We look at prisons. We see this all the time in prisons, where we'll get to 60 or 70% of the population infected, and then it continues to transmit after that, but much slower. So the whole concept of herd immunity for this disease is a challenge in that for us to get there without vaccine, we're going to clearly see an increased number of severe illnesses and deaths, just plain and simple. The second thing, though, is herd immunity is going to be a relative term with us because, in fact, we have a situation where we're looking for durable immunity. How long does it last? As I mentioned earlier in this presentation, we know that people's immunity wanes, and whether it's going to last for 12 months, 18 months on average, we know we have people who have been previously infected who have had second infections after 4 months between episodes. So that, at this point, this is not going to be as straightforward like you have a measles shot or have clinical measles and you're protected for a long, long, long time. This one is going to be a more relative kind of event, and we're going to be learning a lot about this over the course of the next 12 to 24 months. So I think you can achieve herd immunity. You can slow down transmission substantially with this virus, and we want to do that with vaccine, but don't think that that's going to be permanent. We're going to be dealing with this virus for many, many more years to come.
I want to come back to the vaccine and the anti-vaxxer story as well. You touched on this. Remarkable that the percentage of the population in the U.S., in particular, who have said they are not prepared to go the vaccine route. What do you think? What measures can public health officials, epidemiologists, the doctors, the people like yourself take to instill greater trust, a greater confidence in this? And I know this is a big question, Michael, but how best to win people over to the vaccine piece?
Well, I think at this point, you've laid that out very well. Winning them over, I think, is going to be a challenge in the sense of what does that mean? To me, a vaccine is just a vaccine. It doesn't mean anything until it becomes a vaccination when it's in somebody's arm. And I think that what you're raising here is this other half of the population that doesn't believe that they want to take the vaccine, one, because they are concerned about its safety and all the politicization that's occurred, which, didn't materialize. We didn't see an October surprise happen where the vaccine was brought out prematurely before all the safety and effectiveness data were collected. So I think that's a good thing. However, though, there's still people who are going to be skeptical. I have participated in several meetings in the communities of color, Black, brown, and indigenous populations where the distrust of vaccines in these populations is incredible. Some populations, inner city areas, et cetera, where we're seeing over 70 to 80% of people are unwilling to take this vaccine right now out of fear, feeling like they're being guinea pigs. And I understand that. And so we do have a lot of work to do. And it's got to start within the communities themselves. Me, and I'm an old white guy, what can I bring from a credibility standpoint as a scientist? What we need is all of us to come together as if we are all one family trying to help each other. And what can we do to help educate those people? And so, and education by itself, we've come to learn, is not enough. We have, unfortunately, there's a convention every year that's held in this country of people who believe that the earth is flat. And last year they had 1,400 participants that came. I don't have any doubt that we won't necessarily ever achieve major consensus, but we need to get as many people as possible, not only protect them individually, but to reduce the transmission we see within the community.
Michael, will you take a vaccine? How will you decide which vaccine you take if you have that choice? And do I get my kids who are 13 and 15 vaccinated?
Yeah. Well, at this point, I just want to be really clear. Again, this goes back to my nonpartisan statements. I think the FDA had some challenges early on in how to deal with the therapeutic agents and the testing of approval for COVID-19. There's no question about that. I think that Dr. Steve Hahn, the commissioner of the FDA, is a man of incredible integrity, great honesty, and a very bright scientist. The political workings of Washington, D.C., I think, really put their thumb on the scale about what FDA did early on those. But I can tell you right now, I have complete confidence in the FDA process with the current people in charge in regulatory science area at FDA, with the committee of outside experts and Dr. Hahn's very clear and compelling message that no vaccine will be put out there before it's time. And I am, for one, very confident that if they bring a vaccine forward right now, it could be just as well me sitting on that advisory committee saying yes. I will look at the data. I will, not just blindly do it, but I am 100% confident right now that when the FDA approves a vaccine, if left to their own, if the White House should interfere, then that's a different story. But if they're left to their own, I am convinced that we will have the information all of us needs to know that these are safe and relatively effective vaccines.
Okay, and what about the current therapeutics, the current treatments out there from the Regenerans of the world? How much have we learned since the beginning of this year, and how encouraged are you by the efficacy of these therapeutics?
Yeah. Well, I think one of the untold stories of great success, we know about it inside baseball, you might say, but I don't think the public knows about it nearly as much, is just what the intensive care medicine docs and even some of the hospitalists in this country, and for that matter around the world, have done to improve outcome with this disease. This is a very, very complicated infection. It has its own, the virus has its own damage that it does, and then it turns the immune system on so that part of the damage is just from the immune system itself. So we end up becoming, in some cases, our own worst enemy. And this combination is really difficult to treat. But the intensive care medicine teams, doctors, nurses, respiratory therapists, et cetera, have learned so much that we've seen the fatality rates of people who get into the intensive care units compared to last April to now are at least 60% below what they were in April. And it's just because of this much, much better management of patients and how they do it. And so that part's been really good. And not any of it has had to do with a blockbuster drug, not any of it. Okay, it's just been, mechanical ventilation, how you keep oxygen to the lungs, how you deal with using steroids for the inflammatory process that occurs, et cetera. Having said that, we sure all want a blockbuster drug. And right now, I think we've seen remdesivir is potentially helpful, but it's not anything close to what people had thought it might be. We already know about hydroxychloroquine and the disaster that situation presented. And we're looking at plasma right now as another possible treatment, but the data are really mixed on that. So then along comes the monoclonal antibody, Regeneration you mentioned. And that one is also very complicated in that that they just stopped a trial that they were working on with Regeneration last week for people who were late-stage disease. The evidence clearly points to, if this is going to be successful at all, it's got to be given very, very early in the infection process. And that's a challenge because, we're reporting up to 100,000 cases a day right now. And if you look at the stockpile of Regeneration out there right now, it would be exhausted in less than a day. And who would be the priority people to get it? If I turn up positive today, who should get it? I'm not sick yet. Maybe I won't get sick. And to deliver this infusion of this drug is really complicated. It's not like you can just take a pill at home. You've got to basically go to a center where it can be infused. And so, there's a lot of challenges with this yet. It surely holds the best hope for keeping people from going from mild illness to severe illness, but the roadblocks or challenges are immense.
More questions coming through, Michael. And I'm going to link this with a question I have. Again, it sort of relates to what's going on here in the UK. I know you say you don't like that phrase lockdown, but the UK is going into lockdown again on Thursday. But my kids are going to school. My daughter gets on the subway every day to go to school. My son gets on the bus every day to go to school. That doesn't make any sense to me. If the rest of us are locking down and we're not allowed out, why are our kids going out on the subways and then mixing with their friends and then coming home. Does that make sense to you?
Well, I think what people are all trying to accomplish is a Goldilocks response. You know, where can we kind of, you know, trade off? How can we reduce risk here and how here? I mean, for example, let me just say, without a question, bars and restaurants have been a major source of transmission. It has. And has been the home. The home has too. And so you can easily identify bars and restaurants and say, okay, that's not a place to go right now. But the whole school issue is one where they're saying, well, this is for the well-being of the child. You know, they need to go to school. This is what's happening here. So you don't have to go to bars and restaurants, but you should go to school. Yet I do agree with you that kids are, in many instances, going to bring the virus home, and we'll see transmission. So I think everyone is trying to thread the semi through the needle right now, and it's really difficult to do. But I think it's where these illogical, if you're right-handed, you have to stay home. If you're left-handed, you can go back to work. You know, well, that makes no sense. You know, so we're trying to find basically what is the right combination that will reduce transmission that causes the least disruption to society. And I think we're a long ways from finding that yet. And I think the example you just pointed out is a very good one of that very issue.
The reason I ask it, a question has just come through from one of the viewers saying, look, most people are wearing masks, millions of people are working from home, we're washing our hands, you know, we're social distancing, we're not gathering in huge crowds. Why is this continuing to spread worse than a seasonal flu? And let me add into that as well, I'm pretty sure I read somewhere that some flu seasons in some southern hemisphere countries have been skipped altogether because we're better at the social distancing and the protection now.
Yeah, I think, Alex, so I have to declare you an optimist, and I credit you for that. Thank you. We need people like you every day. But when you say most of us are doing that, yeah, most people aren't. You know, as much as we say people are distancing and people are staying apart or people are not getting together, people are not having these kinds of interactions, we're seeing most people still do. They find other ways to do it. So they may not be at the bar and the restaurant, which will surely slow that down. But then they get together elsewhere, and that's what we've been finding. So I think that even when you have areas in the United States, looking at the upper Midwest right now where, you know, basically every day the news you're hearing over and over again is house on fire, house on fire, house on fire, and yet people are still out there, you know, with packed bars and doing things that they may not, you know, even legally supposed to do, but they keep doing. So I think that it goes back to the issue of where I would suggest that, you know, we as a society have to understand what's going to happen, and I worry we won't until we get that 2 a.m. call that someone's died as opposed to seeing it on the drive along, and that's what's happening right now. I really worry about that most people aren't taking this nearly serious enough.
Yeah. Yeah, there's a few other bits and pieces I want to get through, Michael, and this is a data science AI series, so I just want to come on to that because I find this quite interesting, the extent to which data science AI can be used to fill in some of the blanks perhaps left by science. You know, we talked about China, the use of AI there to counter this, to restrict movement, mass surveillance, but other ways as well. I'll be interested to hear your opinions. For instance, speeding up genome sequencing, making faster diagnoses, better access to publications, that sort of thing. How can data science and AI help now?
Well, I think AI can be a critical part of this, but I would also emphasize AI means nothing if you can't change human behavior. And that's the difference between, you know, we report out 100,000 cases last week. We had data on a lot of people, but did it make any difference in terms of what the people did or didn't do? Whereas, you know, I gave examples in Asia where it has. And so I think part of it is we far too often, you know, take all these statistics and all this information and put it together and write wonderful, great reports with lots of color, and oh my, they look good. But in the first instance, it changes anybody's behavior. And so I think that the intelligence is not just the part of what's a unique data set that gives us a new observation that can be important, but what's the relevance to changing human behavior. That's the part where I think we disconnect far too often. And I see lots of extensive AI efforts that in the end don't make a damn bit of difference as if they were done or not. And what we have to find is a way, and I see a lot of public health actions or public actions that are not informed by AI, and I could argue, why did you decide to do that? And so I think it's the marriage of the two. I like to jokingly say, as I believe that both peanut butter and chocolate should be food groups, that it's the peanut butter and chocolate running into each other in the hallway that we need right now. We need AI, and we need the ability to use it to bring about behavior change.
Yeah, I like that. I've got to say, I like that. But what about the use of AI and data and data science in the development of vaccines? I mean, that's something else, right?
Yeah, that is. We're going to need extensive data on these patients or individuals who are vaccinated to find out what their future holds. You know, how long does the vaccine work? What kind of protection does it provide? Are there adverse events that we just want to be certain that are not due to the vaccine? Remember, if you take 1,000 people and follow them for a couple of years, you're going to have people who have bad health things happen to them just by chance alone. So the question is it really related to the vaccine or not? So this is where, data are the ultimate positive four-letter word. We need that. And so that's going to be a very important piece. And again, the ability to do that quickly, you don't want to spend days trying to pour through information that, you could obtain with a push of a keystroke and have within a nanosecond. That's what we want to be able to do.
Yeah. Right at the beginning, well, I say at the beginning, so back in February, I did speak to a lot of the pharmaceutical companies, some of the biotechs, the Regenerons, the J&Js. I spoke to Peter Bach about this as well. And one of the things that came through quite clearly was, while collaboration and partnership at the policy level between governments is pretty shambolic in our response, when we look at pharma companies and the regulators and the clinical community, we've seen a sense of working together, a partnership. Do you think the enormity of this crisis, Michael, can ensure that the industry, the pharmaceutical industry, can come together and work together to find long-term solutions?
I think yes, but let me qualify that by saying it sure doesn't hurt to have a boatload of money. And I think that the federal investment in this has been so unique that that's been a major incentive for people to get involved. And let me just give you a case in point. I was very involved right after 9/11 with trying to help out the U.S. government in terms of preparing for a potential another attack, bioterrorism, et cetera. And so I split my time between University of Minnesota and the Special Assistant to Secretary Tommy Thompson. And we started at that time the program called BARDA today, which is basically a program that was meant to help incentivize the pharmaceutical industry to get involved in some of these therapies or vaccines that would be basically for rare diseases, but when they happen, they're a big crisis. And you know what? We couldn't get one big player involved. Not one of them wanted to. Not one. And it wasn't enough money. It just wasn't the risk portfolio, and the opportunity costs were just too great. And so I think that we all know this intuitively, but it's sure sometimes good to be reminded of it. Money sure helps. And I think that's been the challenge is right? We have a lot of people coming forward right now, but it's in part been on the money.
Do you think, though, in a dare I say it, a post-pandemic world, there is going to be lasting positive change in the government's attitude towards spending like this?
Yeah, I think at some point we are going to be asking ourselves, down the road, it's going to be one where I still can't tell you what's going to happen next spring or next summer. If this vaccine only has limited impact on our society, we really are going to have to reevaluate how do we live life every day in the public places. Will we ever go back to major, in-building operations? Will people be working from home a lot more? If you're an essential worker, you don't have that luxury. When's the last time you saw a checkout clerk at a grocery store working from home? And so I think that this is going to be a redefinition of essential workers, of how we do work, period. What is work product? How do we support people from a safety standpoint and from an emotional, economic standpoint? So I think this is going to be one of the most tumultuous periods of time from how we do business in the world. I don't care what kind it is. And how do we redefine that? And, you know, I liken it to think of what happened with the advent of electricity before and after. I mean, things changed dramatically in this world. Public health changed completely because once you had electricity, you had water pumps. And once you had water pumps, you could actually, you know, have safe water supplies and treat sewage. And you could do refrigeration and have safer foods, and you could make vaccines. I think we're at another stage like that, where we're going to be looking at bringing all these people together. What does it really mean if we can't do it with the level of safety that we had grown accustomed to?
Yeah. And I just to draw that out before we close as well, this idea of how we make societies, how we make our world more resilient to pandemics, this idea of resilience planning, we really need to start thinking about seriously now. Would more spending on virology and epidemiology help prevent future pandemics, do you think?
Well, it can surely help us be better prepared. You know, I laid out a detailed plan in my book, Deadliest Enemies, published in 2017. What we need to do, prepare for the next pandemic. Chapter 13, ironically, was SARS and MERS, a harbinger of things to come, all about what was going to happen with coronaviruses. So we surely shouldn't be surprised. We need creative imagination right now, but it's got to be applied then in a way that says, okay, so what can we do about it? I mean, we don't need any more information to know that we need stockpiles of certain kind of protective equipment for healthcare workers. You can't make it at the time that the crisis happens. Imagine if we had no missiles in our entire armamentarium for the military, and we went to war and said, okay, now let's go do bids, let's get those missiles, and we might have them in a year, okay? We would never think of doing that. Yet we do that all the time with public health issues. We need to change that paradigm.
I mean, you mentioned SARS and MERS. I mean, this is animals to human transmission. Is that, do you think, the new norm? Is that the next one and the one after that as well?
Well, it's not going to be SARS or MERS as such. What it's going to be, though, is a coronavirus like that. Influenza is still there. I mean, think about this. There are 23 billion chickens on the face of the earth right now. Half of all the body weight of mass for avian species is in chickens. And it's to feed the 8 billion people that need protein. We got 390 million pigs on the face of the earth right now to feed the pork needs of the population. And when you put those two together, they are the most ideal mixing vessel for influenza viruses to create new viruses that can cause the next pandemic. You know, this is not our last rodeo. Trust me, it's not. And so what we need to understand is how can we better prepare for what's going to come down the pike in the future? And knowing that these very rich conditions for new pandemics are there. So I think that that's going to be hopefully a lesson out of this, is that, you know, let's not just get out and say, oh boy, we're done with that one now, we're done forever with pandemics. No. With 8 billion people on the face of the earth, 1 out of every 8 people ever lives on the face of the earth right now. With all these animal populations, we are going to see more and more of these events, not less.
And as part of that, I mean, in your abstract, you mentioned being able to paint a picture of how the world's going to look a year from now. I mean, and we've talked about many things that you feel will happen and how things will look. But what's the biggest change, you think, Michael, 12 months down the road?
Hopefully we have much more humility in understanding us versus the microbes. You know, simple little viruses, just simple. They're not bullets. They're not bombs. You know, they're not computer viruses. They're just plain viruses. And look what they do to us. And, you know, we're all going to die. Everyone is going to die. There'll always be a top 10 causes of death. But I think we can all agree that we don't want to have these pandemics overlaid on our society because they're ruthless. They are economically incredibly painful. And they challenge the very nature of who we are as humans, trying to communicate with each other. So I think that if nothing else, we come out with a sense of humility about what do we need to do to better prepare for dealing with these quote unquote infectious viruses.
And are you confident that that we as a species have it in us to find that humility?
I do think we do. I think we do. Our creative imagination is there. I think that, we can take men to the moon. We can do so many things. This is one I think we can much, much more effectively prepare for.
We here in the UK, we've got this so-called lockdown coming, not allowed to mix with anyone outside our households. So, I can, if we did indeed celebrate Thanksgiving here, I'd be here with my wife and 2 kids. A cheeky question comes through for you saying, how many people are going to be at your Thanksgiving table?
Just my partner and me. That's it. And we're doing virtual with family members.
Okay. Yeah. Great, because I think that's one of the biggest worries here, as Christmas approaches, just exactly how that's gonna happen. Look, Michael, we've kept you for a long time, and I really appreciate your thoughts and your candor, and it's been really, really refreshing to hear you talk. As I said at the start, I've spent the best part of this year speaking to mainly just sort of policy and business people about this, and boy, is it refreshing to talk to the David Haymans or the Peter Piotts and the Michael Osterholm. So thank you very much.
Well, thank you, Axel. You did a great job. You obviously understand this topic, and thank you for that. That's part of the storytelling. You're part of the storytelling group. We need you.
Well, I'm delighted to hear you say that, and I appreciate those thoughts. Look, I want to thank everyone for watching and for listening, and also for your questions, which have been some good ones too. And that just remains for me to say goodbye, stay safe, everyone, and we will see you next time. Thanks very much indeed.